Hello and welcome everyone for tonight's EAO Just Ask. Today or tonight, it's the first Just Ask of this year. So Happy New Year and Healthy New Year to everyone. But it's not only the first Just Ask of this year, it's a very special one because we have a top-notch expert here. And we have a friend who we lectured many times together, did a lot of projects together. And I truly call him a friend. Tiziano Testori is my guest on behalf of the EAO tonight. Tiziano, a very warm welcome and also a happy and healthy new year to you.
Thank you so much.
Tiziano, it's no need to introduce you to our community. There are already a lot of people logging in for you. People from Spain, from Norway, from France, from Poland. People from Uganda are logging in, so they all want to hear your content, Tiziano, what I can totally understand. There's no need to introduce you. You're world famous. You published so many books. All of your books are in my shelf behind me. You're affiliated with many prestigious university, Milan University. You are affiliated with Michigan Ann Arbor and also Harvard University. You have your own educative and research institute in Lake Como. You are a top-notch surgeon. You earned a lot of prizes, and actually you will lecture at the EAO Annual Congress in Monaco this year. So everyone, please subscribe. Again, a very warm welcome to Professor Tiziano Testori.
Thank you so much. I'm really pleased of your introduction. You are too kind to me. It's a long story. 43 years in practice this year. I started as a medical doctor in '85 because at that time you should be doctor before being a dentist. And then I created a group of people, of students that are helping me out. So I should acknowledge all my team because by myself, it would be much harder and I could never achieve what we did because it's a shared effort of everybody. And I really remember the first time we met was in America many years ago during a meeting in America. And since then we became, and we always be good friends, and we lecture so many times together. So it's a real honor for me to be here, and I'm really pleased that you are the moderator, Madonna, the moderator. You interact, as you said, as a friend. That's the best approach we can have for all the young guys, all the audience. Thank you so much to the EAO board as well.
I totally agree with you, Tiziano. And Tiziano, I didn't know that you were a true doctor. So if I get a heart attack, you can definitely help me, okay?
Yes, yes.
So Tiziano, today our topic is actually, I guess, a little bit your favorite topic. It's sinus lifting. And actually, a case came across my office. I finished a case where I did external sinus lifting. I did a staged approach, waited for 6 months, placed my implants, uncovered my implants 4 months later. And these are the radiographs. And I thought, I have Tiziano Testori with me. Should I show him the case or should I not? Maybe he will say, oh, Stefan, I'm not sure. But I just say, Tiziano, have a look. What do you think? Would you do something different? Of course, you don't have a lot of information, but what is your few sentences on that case?
That I would do just the same tomorrow morning in my office. You know, you did a lateral approach because you have a minimal quantity of bone in the posterior. And it's much, let's say, safer. You can still control perforation, everything. So the approach that you chose is the most documented approach in the literature. We did some changes over the years, so we can say nowadays this approach is minimally invasive because we change many things that we will see together. So even if there is some rumors that you got to do everything from the crestal, I think that what you did is up to date, and tomorrow in the office for the same situation, I would do just the same. 2-stage because it's safer, wait, uncovering the implants, and do a predictable restoration. Nothing to say.
Tiziano, the evening is just done for me. I'm going to get me a glass of red wine. That should be it. Thank you for this. And I think this is the first information we get out of this evening, is that maybe these old-fashioned things are not so bad. We shouldn't run for all the new things and innovative things and so on. But Tiziano, people are here from Mexico, from Bulgaria, from Spain. They want to hear your content. You promised us to show also something new. So I'm also a little bit anxious what you're going to show. And as you know, it's a little bit the routine of this Just Ask. I allow me to interrupt you whenever I think it's a good moment to discuss, because it's always nice for the people, and also ask the people in the chat, please ask your questions. I will hand it over to Professor Testori. Tiziano, we will be more than happy to hear your lecture.
Thank you so much. So it's very important to know a little bit about sinus physiology and what has changed over the years regarding this sinus physiology, and when to refer to an ear, nose, and throat specialist, our patient, before doing the sinus. So if you want to have a predictable procedure, we need to start from an healthy sinus, and what we check that we have the natural ostium that is open. So our CAT scan are done up to the orbit in order to check if the ostium is open. We have been working with ENTs for more than 30 years. I used to be an ENT in my early years of my practice because my uncle was the ENT here at the local hospital in Como. So my passion for the sinus started because I've done, when I was a student in the first 3-4 years, a lot of sinus surgery the old way with my uncle. The true story, then I wanted to be independent and I switched into dentistry. That's why I understood from the beginning that you need to know something about sinus physiology if you want to do sinus lift. So the first clinical message, starting from tomorrow, when you need to elevate your sinus, is better to check, to have a vision of a CAT scan that is not halfway at the sinus, but it goes up to the ostium, and the ostium should be open. This is an intra-op view with an endoscope through the accessory ostium, showing you that some blood is coming up towards the ostium. You know that without knowing, everybody of us is swallowing almost 1.2 liters, 5 liters of mucus every day. That's why the sinuses are considered sterile if there is an efficient mucociliary transport. Why it's that important? It's that important because we wrote the latest guidelines on when to refer the patient in order to minimize intra-op and post-op complications. And among the authors, we have the ENTs that we are working with, Felizati and Saibene. The new stuff is the thickening of the membrane is not the issue. The issue is if you have an open osteum. Everybody is still concentrating too much on the thickness of the mucosal membrane. We don't care too much because we have seen over the years, publication has told us, and there is evidence in the literature that quite a few of your patients, they have a thickened mucosa, but with an open osteum is not a contraindication. So we have this, that on the one side, a completely healthy sinus, you cannot see anything regarding any thickened mucosa. On the other side, you have a thickening of the mucosa, but if you have an open osteum, you should not refer the patient to an ENT. You can have a blocked on one side and you can have an open osteum on the other side. So mucosal thickening due to periapical periodontal lesion is just a common situation. So the main problem is you have to treat periapical and periodontal lesion before doing any kind of sinus lift in between your edentulous spaces. Mucosal cysts that do not interfere with the sinus elevation, leave them. Why? Because 30% of your patients, they have a mucosal cyst without any kind of problem.
Tiziano, can I interrupt for a second? What
Sure.
do you mean they don't interfere with your sinus lifting? So they are not in the area where you do your external sinus lift?
Yes. I mean, you have a mucosal cyst on the anterior part of the sinus lift, on the posterior side, down in the floor of the orbit. Leave them.
Okay.
Usually we aspirate those cysts when they are interfering with the elevation, because it's much more complicated to lift the sinus with a mucosal cyst attached to your Schneiderian membrane.
But could you do that one stage or two stage with the sinus lift?
We do one stage, and we published that last year. You can find sinus mucosal cyst aspiration. That means that cyst, the term is it's a misleading. We should call them mucosal retention cyst, in which one of the ducts that are pushing the mucus inside the sinus, that are producing the mucus inside the sinus, is blocked. So there is an accumulation of mucus within the membrane. You should remember that the membrane has 3 layers. The periosteal layers that you see when you do the sinus lift. Then you have a middle layer in which you have the cells that are producing the mucus. On top of the cells, you have the cilia that are beating towards the osteum. And on top of the cilia, you have the mucus. The cilia are beating in an aqueous solution. On top of there is the mucus. So the mucosal retention cyst begins between the cilia and the periosteum. So it's not epithelium inside, it's just a retention of liquid that cannot come out. That's why if you aspirate the cyst, it will not reform because it's not surrounded by epithelium. So leave the cyst, and if you wanna, that do not are in the area of the lift, and if you have cyst in the area of the lift, one of the easiest way is to aspirate the content, because 90% of the time are liquid in content. But you can
and
go
Tiziano,
on.
one question: if you aspirate, can that be a starting point for a perforation? That's always a fear I a little bit have.
Yes, it can be, but let's say the minute you go through the periosteum, you stop and you start aspiration. It's like doing, like you're a periodontist, like doing periosteal incisions. You should stay within the confine of the periosteum. So if you go just past the periosteum and you start the aspiration, on top of that, since you have a ball, even if you go a little bit deeper, you will be inside the cyst, and maybe you have 15 millimeters before doing a full perforation.
Got it.
Because a full perforation means that you have to go through the periosteum, through the middle layer, and through the cilia.
Got it.
So your needle is within the periosteum, thickened because there is some liquid between the cilia and the periosteum. And we did some histologies on that paper, so it's very easy and understand why cyst form, and why without the right terminology, mucosal retention cyst, it's misleading, but it's something within the membrane. One clinical message that is very important is every time you see that this erosion of the bone is not due to an infected tooth, perio, or let's say endo, it's better to refer the patient, because it's not so frequent, but there are some kind of carcinoma, inverted papillomas. Always remember that when you have a CBCT, you are not able to differentiate between liquid and solid. So in these cases, you see a CBCT, you see a opacification. But to differentiate a liquid from solid, you have to run an MRI. This is a case that came to our attention for a second opinion. And the patient came to the university asking, the doctor did not pay attention to this problem that I have on the palate. And that problem, and it was scheduled for a sinus, but that problem was a carcinoma starting from the minor salivary glands, and maxillectomy, and a double fibula reconstruction. So it's important to understand that opacification of the sinus due to an infection most probably will be unilateral. So when you see a patient that has a unilateral opacification of the sinus, most of the time this is due to an odontogenic origin. And the patient are reporting a symptom that is foul smell and taste that is not present in chronic rhinosinusitis that are not due to an infected tooth of implant. That is very important to understand. The main problem is, as we wrote in this Delphi consensus, that everybody of us should speak. So you should refer the patient to an ENT, but with a report that, listen, I saw that there is a unilateral opacification, but all the teeth are healthy. Don't send to an ENT without a diagnosis of every single tooth of the quadrant of the posterior side. Another new stuff is that it's very important to understand that you should classify your sinuses in terms of difficulty score, because the difficulty score allows you to understand if a case is simple or if a case is difficult. It's not an academic, let's say, exercise. It is very important for the young guys approaching this. It is even important for us that we have a little bit more of an experience. Why? Because if it's a difficult case, we are scheduling the patient early in the morning and not late in the afternoon when we are tired. So I'm always saying this kind of analogy. Are we dealing with the central incisor that we have to make the root canal, or the second molar with calcified canals, a patient that is not opening very wide? So all the two interventions are called root canal endotherapy, but one can be very difficult and the other one can be very easy. So it's better to classify, and you can check on this checklist published in JOMI. There are some anatomical reasons that make the sinus more difficult. There are so patient-related. Some can be visualized during your consultation with the patient. Some can be visualized by doing the CBCT. And then there are some even patient-related factors like smoking habits or not. So if you are doing this checklist, you can have an idea of when to schedule the patient or try or elevate that sinus that is difficult after you have done a little bit of a learning curve in the procedure.
And Tiziano, I mean, looking at your experience or looking at someone being more inexperienced, would you also say that if I go up in a score with the difficulty, I might think of not doing an external sinus lift and look for an alternative? Could be a short implant or could be a bridge. Is that also something which could conclude out of your study?
Listen, after 43 years in practice, my first sinus was done in 89. I'm telling you that if I can provide teeth with the less invasive procedure, no sinus lift, either lateral or crestal, short implant, transsinus implant, pterygoid implants, first I check if there is an alternative to sinus surgery. If there is an alternative to sinus surgery, because always remember that the patient are coming not for having the surgery done, performed, but they are coming for beautiful teeth that can be cleaned, they can speak well, chew well, and can be maintained by the home care procedures. So you said right. But if the lateral approach is your treatment of choice, it's better to classify in order to have an easy way to and to see maybe this, I'm starting my career in sinus surgery. Let's check if I'm starting with the central incisor or the second molar with calcified canal. That will make my life easier, because I will be very honest. Do you think that during live surgery we're picking up the difficulty score, the difficult sinus? Zero. We are picking up the simple one. And we say it's more didactic, but the true reason, the difficult case is difficult even if you have a lot of experience. So
Tiziano, let's nail you down a little bit for the participants, because we had Ronnie Jung here, I think last time or the one before, lecturing on short implants. What would be the shortest implants you place where you as an expert think maybe it's a better case for a short implant? What would be the shortest one?
Let's say if we have in between a natural teeth,
single
5 millimeters of bone, and we have no horizontal deficiency, no vertical deficiency. We wrote paper showing you that we are fine with an implant that is long 6 millimeters for a molar and the white diameter if possible. So nobody can say in 2025 that short implants are not predictable. And if you have to place multiple implants, we splint them and we change connection. We want to have a very stable connection. And if we have to do single tooth restoration, we prefer to have an internal, let's say, performing connection. So that is another great point.
Thank you, Tiziano. I applaud you for this comment.
It's a great point. Clinical indication. Clinical indication, always remember that short crestal and lateral approach, there is always an overlapping of indication. So always remember that everybody of us has a lot of biases, and the biases are due to our background, are due to our level of knowledge and to our experience in the real world. But let's say tonight we will be focusing on the lateral approach that I still think is in totally edentulous patient with 1 millimeter, 2 millimeter, 3 millimeter of bone, the most predictable, the most easier way of doing the sinus surgery without trying to expand. The crestal approach can be done on every single patient. We both have friends that are saying that, but always remember that in medicine, there is never and always, there should be a balanced approach. So the lateral approach in totally edentulous patient or patients that are missing premolars and molars, I think the lateral approach is still.
Tiziano, one question. You talked about this, is because this is very interesting also for the people listening. You talked about how predictable the lateral approach is also in edentulous patients, and I agree with you 100%. So my question would do you also sometimes consider edentulous patient just restore with implants in laterally augmented sinuses and just leave out the front, which may be deficient? Is that something what you consider?
Sure. The only thing that we have a publication, an ongoing publication going back and forth, the referee, and it will be hopefully soon published because it's the third round that we call the challenging sinuses. Challenging sinuses are the sinuses in which you have zero bone to start with. So the mixture for, let's say, the recipe for failures when you have a patient zero bone to start with, that they are smoker, that are medically compromised, that they are older in an elderly age, and this we don't do sinus lift only with biomaterial because we need to have in those challenging situations more autogenous bone. So
but still, Tiziano, everything else is complicated in these patients too.
Yes.
So GBR in the front. I mean, it's probably more dangerous, right?
No, that's in the hospital. We found a consensus with the maxillofacial surgeons. In those cases, if they open the door of the maxillofacial surgeon, they got zygomatic implants,
Okay.
no matter.
Okay.
If they are open our door, the investigation is a little bit, let's say, more in depth, but we send those cases in which we see that there is possible failures for doing the zygomatic implants.
Yeah.
So it's, but it's very specific topic. Usually in the patient that you see in private practice, most of the time a sinus lift can be done, but be cautious when you see those patients that they have zero bone. They have been going through a lot of surgeries. They had a lot of failures. They still are still smokers, medically compromised, elderly.
Got it.
So we came out with this idea with Massimo Simeon that we call digital sinus planning protocol. And so we start with a CBCT at the right vertical dimension of occlusion for the future restoration. And this is another information that is very useful to understand when you have to make a sinus lift and at the same time horizontal or vertical augmentation. That means that the sinus lift per se should be left only when there is those deficiencies are not deficiencies that are doing a compromise to the restoration. And to understand why the digital sinus protocol is very important to visualize before the surgery the future prosthesis, because this is a case that came to our attention. The case has a beautiful prosthetic work, beautifully done, but the patient cannot clean this prosthesis. So we said to the patient, you have inflammation around this prosthesis, because from the beginning, that was a case of two options. Or you have a prosthesis that leave a space for you to clean, so the abutments are like in a Toronto Brannemark prosthesis, completely visible, and you have a proxy brush that can enter and you keep your tissue completely clean without inflammation, or this type of prosthesis, usually they end up in a problem. So the patient wanted to wait, but we knew that sooner or later that was the end of the problem, because the prerequisite of the prosthetic reconstruction should be not only functional and aesthetic, but even the possibility to maintain those type of restoration. So all the digital sinus protocol allows you to understand when the future prosthesis will be impossible to be cleaned. In this case, we were able to tell to the patient, listen, we have to remove one implant, but now we will have to modify your prosthesis. It will be still difficult, but less difficult than with the aesthetic type of restoration that you had before. Obviously, you have a lot of foot impaction, horizontal foot impaction in these cases. Why? Because you cannot avoid foot impaction but still the patient can clean in a much. That another issue allows me to introduce another story, and then we will end up at the soft tissue control around the implants. And we ended up with this idea of buccally displaced palatal flap with various Steigman, Zucchelli, anomaly that was to create a quantity of keratinized tissue and to reestablish the depth of the fornix for the patient to be able to insert a manual, or like we say today, we advise the patient to use a rotary. And this is a palatal flap that creates a quantity of gingiva, attach keratinized tissue around your implants. And this is the type of flap that we do with a cutback on the posterior in order to slide the flap towards the midline. What do we change? We change the flap design, and we do more this type of flap design. We learn from the periodontist like you. We are no more scared of prolonging our incision split thickness in the aesthetic area, because we are able to, let's say, to do two interventions at the same time. Giovanni Zucchelli was the periodontist in our office for a while, and then we try to combine our knowledge, and so we change over the years the flap design, and we check the adjacent teeth, and when we have some root recession on the adjacent teeth and we have to do a sinus lift, no matter if lateral or crestal approach, in this case a crestal approach, by changing the flap design, we will be able to address two problems at the same time. So my advice is check the adjacent teeth and see if you can combine some perio and some implants together. So we, as oral surgeons, we were more gross at the beginning. It's only by knowing people like you, like the periodontist, that we should stay close to you in order to better manage the soft tissue. So my advice is be more a periodontist when you do the flap design.
Thank you, Tiziano. Just one question to the anterior vertical releasing incision, which you did. You also do that in a split thickness fashion then, or is that full thickness?
No, full thickness, yeah. 60-degree bevel in keratinized tissue, and then full thickness, because we are not going to do any kind of releasing incision, full thickness in the premolar area.
Got it.
Why? Because if you do in the premolar area, sooner or later you will end up in cutting one of the branches of the alveolar or the infraorbital nerve.
Yeah.
So we stay away from the risky area. So the advice is prolong the horizontal incision. Don't be afraid to go with perio flaps, because you do all the time in your office to do perio surgery. And so you avoid the risky area of creating neurological problem or bleeding problem.
Yeah.
The novelty is even in the type of antrostomy that we do in fully edentulous patient. We start from the mesial recess and we distalize the membrane of the sinus. So it's not an elevation, but it's a distalization to start with. So we got rid of all the blind spots. Historically, we were leaving 2-3 millimeters, 4 millimeters of bone and mesial to this. distal to the anterior recess. Now we are starting our antrostomy right at the mesial wall of the sinus. And we prolong our incision towards the distal because you avoid working in a blind spot. And with this simplified antrostomy design, you will decrease the perforation rate dramatically. Why? Because you are not working in a blind spot. You don't need
Tiziano, this also gets you rid, I think it's a great tip, gets you rid of a major mistake I often do, is because you have the blind spot and you don't elevate enough in that area. And that's exactly where the implant needs to go. So you always have a small recessions of bone there. And it makes me crazy.
Yes, so in fully edentulous patient or patient missing the premolars, start tomorrow from the mesial wall, because one of the mistakes that are done by many, even experienced practitioners, is historically to leave the little piece of bone that makes your life miserable. Remove the little piece of bone, so you can see directly what you do, because you see the membrane, you see the junction between the mesial wall and the membrane, and you push your membrane distally.
It makes sense because you also look from the mesial, you look from the anterior, so you see better.
Yes, that is a great piece of advice. If you have to do the sinus like you did, and you don't have the premolars, it's easier. We do the simplified antrostomy design. If you want to be very technological, you can ask a sinus guide, and the sinus guide gives you where the mesial wall is, where the sinus floor is, and in totally edentulous patient is very useful. So this is a case in which our flap design is a flap design split thickness towards the midline. We stay in keratinized tissue. The minute that you start doing vertical incision in mucosa will start bleeding. So it's a dynamic flap design. We stay with a prolonged incision, horizontal incision in keratinized tissue. If we need more release, we go up in the mucosa, but it's not always the case. So this is done at the mesial part of the sinus, and for you it's much easier because here is the junction where and if you leave 3 millimeters, 4 millimeters of bone, you have to work inside the blind spot. For years we have done that. And when we started doing the simplified antrostomy design, we ask ourselves why we were so stupid. And for so many years, we made our life miserable, leaving those 3 millimeters of bone and forcing us to work in a blind spot.
Tiziano, I ask myself tonight, I'm 47 now, I hope you were a little older.
And then nothing has changed. One of my good friends, Terry Zaniol, said, good idea to get rid of that blind spot, but why not lower the window and start flush with the sinus floor, leveling with the sinus floor? So we have all around no blind spots. And on top of that, your window will be lower and there will be less bleeding problems, because the artery usually runs 1.5 to 2 centimeters from the crest. So the low window design and the simplified design combined together are easier, sinus lift procedure. Why? Because you don't see, you don't have any more blind spots and you see what you do. And that allows you to minimize perforation. Conclusions. Always remember that the lateral approach was regarded historically as a more invasive procedure compared to the crestal approach, but was due to the flap design, not because we are lifting the sinus. And if you change the flap design into a perio implant flap design, you will reduce the invasiveness. Why? Because you have more swelling, more post-op every time you cut through the muscles, every time you cut in the middle layer in which you have muscles, nerves, lymphatic. And so full thickness, long incision, not cutting into the muscle will decrease the invasiveness of the procedure. The simplified antrostomy design and the low window design will make the procedure more predictable because you decrease the level of perforation and decrease the level of bleeding disorders. Because be minimally invasive is not only decrease the post-op for the patient, but even decrease the intra-op complications.
But Tiziano, then the painting is wrong. Go back one slide. If you start at the floor of the sinus, your schematic drawing is wrong. You have to change
Yes,
it.
you know why? Because that we're drawing
I'm
from
joking.
the old book that we wrote, and
But
we realized
you see that I'm looking in detail.
Yes, the old book of the sinus, where we are so stupid to leave that 2 millimeters, 3 millimeters of not flush with the sinus wall,
I love
sinus
that
floor,
tip. Thanks.
make our life more miserable. You are a super doctor. That's why you pay attention to the details, because the devil is in the details.
It is. It is.
I took a note. We have to change the door. Yes, true. Yes, you are. So multiple implants in edentulous patients with the little devices that I gave you. I think you make your life easier for you, easier for the patients. And still what you show at the beginning of your lecture is not obsolete. I do think that is a standard of care and should be done to our patient with these little modifications. So thank you so much for the invitation, and very condensed, these are the novelties in diagnostics and the novelties in, let's say, procedure guidelines.
Tiziano, that was amazing. I applaud you for your lecture. I applaud you for your knowledge. I applaud you how you interact science with clinical work. I don't know how you do that. Congratulations also on behalf of the EAO. It was an amazing lecture. Thank you very much. Tiziano, there are many questions from people all around the world. And actually, by the way, people are applauding you. We're already a little ahead of time, but I still want to pick up a lot of these questions. I think the most famous question came up, obviously, do you mix autologous bone with bone particles, yes or no? A quick answer.
Quick answer. Most of the time with sinus that they have 3-4 millimeters of bone to start with, no.
Okay. So if you have zero bone, what you alluded to, you probably would, right?
Zero bone, we do the mixture like we do the mixture for vertical, 80%, 70% of autogenous bone, and the rest is biomaterial to decrease the resorption rate. But this is zero bone stuff. So don't blame the biomaterial, blame the lack of knowledge. So in those cases, you need to have an osteoinductive biomaterial that is autogenous bone
Yeah.
of the patient.
Thank you. There's a great question from Pascal. Pascal Valentini. Hi, Pascal. Thanks for logging in. Also a friend of ours. He has a very clever question, which I expected. How do we see long-term complications after sinus lifting? And obviously we do. We sometimes see bone loss. We sometimes also see loosening of implants, very seldom, but just have a quick take on that. We also sometimes hear people saying that bone replacement material is not a true bone and it will get lost some point in time, which doesn't seem to be true. So just your take on that. Do we see complications, and what is your take on that discussion?
First of all, I would like to say hello to my boss, because you know that Pascal Valentini is my boss. He speaks Italian, he always calls me and says, Tiziano, you have to do this, and I obey to my boss. We will be sharing the podium in Monte Carlo, but I was invited by Pascal to share the podium on sinus lift, and we have been working for decades. Let's say what we, over the years, what we saw that we have to pay a lot of attention to recalls, because one of the main reasons for failures of sinus lift is related to periimplantitis. So all our patients that have done implants are in what we call implant periodontal protection plan. That is something that we are going to publish. We submitted this idea in order to give a benefit to our patient. And with the implant protection plan, we do a protection plan of those implants if the patient is coming for maintenance at a certain time point according to their risk factors. So it's like I took the idea from the car dealers. If you have your car serviced, always in the official car dealer that you bought your Audi, your car, your German car.
I thought you only drive Ferraris in your country.
I mean, a Ferrari is very, nobody of us is driving Ferrari.
I'm kidding.
Ferrari, it's, I will be killed by Ferrari company, but Ferrari is not so famous in Italy like it is abroad. Here, if you, like a dentist, are going around with a Ferrari, they look like...
You have a problem.
No, we have a problem. I mean, we like to be more modest, and we are more than happy with German cars.
True.
So, to go back to what we said, if the patient is coming to our offices for recalls, they are insured. They have this protection plan, like when you buy an iPhone. You want to subscribe to a protection plan, yes or no? You sign a contract. So if the patient is coming every 3 months of the first year, if you are very super great, you can have scale down to 4 months. If you are super, every 6 months. But if you are not coming to the office, you didn't subscribe, if you have to redo the prosthetic and the work, we are allowed to charge the patient. So the protection plan allows you to increment the recall program, because you give them this that is called protection plan. And so we tell to the patient, if you're coming, but every 3 months you are a periodontist, I can see mucositis, but not periimplantitis. So if you check and you have dental hygienists that they are clever, this problem, we don't see that.
I get it. Tiziano, we already are a little bit off time, and you know how important time is for Germans. I would allow one final question, and this question has come up twice, and all the other question, please Tiziano is in Monte Carlo. Approach him. He's lecturing at the Sinus Lift session. So please take your questions to him. Tiziano, we talked a little bit in the very beginning about the modern stuff, osteodensification. What is your take on that? Is that going to stay? Is that an alternative? You sometimes see crazy cases, millimeter of residual bone, elevating it up to 10 millimeter. What is your take on that? A good thing? It's ballyhoo, or it should be more tested? What is your take?
Osteodensification is a wonderful technique. We stay within the confine of what it's written and it's evidence-based. In 2 days, I will do a webinar on osteodensification, and I fully research the literature, 119 papers on osteodensification. So up to now, we cannot say that is not evidence-based. We need obviously more research, more, let's say, randomized clinical trials. But really, once you learn the technique, once you have done your learning curve, once you don't want to do it to be a super achiever and use osteodensification in every single situation, osteodensification for the crestal approach is our first choice. But we do osteodensification when we have at least 3-4 millimeters of bone, and is type 3, type 2 bone. We use osteodensification with biomaterials if we have a type 4 bone, but we stay within the confine of what is common sense. There are established clinical protocols. So every time we have 4 millimeters and we need to place 7.5, 8 millimeter long implants, that's fine, is our first choice. So up to now, we cannot say that osteodensification is not a great tool, a great technique. The only way is the extremization of the use of osteodensification. I know exactly that some good friends of mine, your friends as well, without naming them, they're using osteodensification, but they are extremely skilled. They are extremely, but can that approach be predictable in the average end of the average implantologist? Or we should send all the cases to the one who is very gifted? I think that the technique should be predictable in the hands of everybody that is well trained in implantology. On osteodensification, there is a learning curve.
Yeah, well, that's a good point. So up to 4 millimeters, that's a predictive approach. That's also my perspective. And I think our maybe message is clear. Don't overdo it, in particular in the beginning, because the classical way, I mean, it's not that invasive. I always have the feeling in my patients, especially if you're experienced and you're quick, and I'm gonna do it with your technique tomorrow. Tiziano, it was amazing. It was amazing. It was a great lecture. It was just a great talk. Actually, almost an hour vanished. What do you say? It is like this. It was great. I thank you on behalf of the EAO. Please,
Thank
everyone,
you so much.
Come to Monte Carlo. There's a super early bird registration fee, I think up to February 6th. So very, very cheap. You can see Professor Testori, you can see the stage, everything. So subscribe to the Congress. And with this, Tiziano, we all want to say thank you. All of the participants, they applaud you. I'm sorry I didn't get all the questions for you. I think they will all come up to you in Monte Carlo with the questions. But anyway, I think you're also reachable. You have your email address here. I think they can be happy to come to your institute for courses. Tiziano, it was amazing. Thank you on behalf of the
Thank you
EAO
so
for
much,
making
and
this
thank you
possible.
thank you to you. Thank you to the board of EAO. Thank you to Pascal Valentini that will be sharing the podium in Monte Carlo with me. Thank you so much for all the attendees around the world. And thank you for your friendship. And thank you for picking up the wrong drawing.
Okay, that's the picky German. I'm sorry for that. So, good night to everyone. Thank you. Ciao, ciao. Ciao, ciao to all around the world. See you next time, and see you in Monaco, Tiziano. Ciao, ciao.
Thank you so much. Take care of yourself. Bye-bye.